So I'm going to talk today on adherence. I'm going to be just giving you definitions and then a little bit about how I think we can help overcome non-adherence. So I have no financial disclosures or conflicts of interest. I'm going to describe the types of non-adherence. Can everybody hear me? No. Okay. How about now? I guess I need, okay. I'm going to talk about the types of non-adherence, list some barriers to medication adherence, and then present just a few strategies. So what is a definition of adherence? Adherence is following a prescribed treatment regimen. It's like, I would like you to do this. The earlier word, and a lot of us still use compliance, that has more of a patronizing. It's like, what you are to do is this. So we have switched to the word adherence. It's a little more user-friendly. Where we'd like to go is therapeutic alliance, medication intake following shared decision-making. And that would, the discussion would be, this is what we have agreed to do today, so that you and the patient have agreed on that. Non-adherence, how prevalent is it? It's estimated that 50 to 75% of patients do not adhere to medical advice. Now that can be not just medication, but other treatment regimens. And what are some of the non-adherence rates? Failure to keep appointments is 20 to 50%. I don't know if you can see. Stopping treatment early, a lot of patients, including probably ourselves, 20 to 60%. Not following instructions, 19 to 75%, and error in taking a medication, 25 to 60%. Now there's several types of non-adherence. Not everybody does this on purpose. So there's intentional. Intentional non-adherence is you're feeling better, so you stop the medication. You know, some of us do that with antibiotics, but see, I'm not the only one. Fear of addiction, so they don't, you don't want to take inhaled steroids, or you can't afford the medication. That's intentional. Erratic is you're too busy, you're too stressed, or I put in red the chaotic lifestyle, which I think is a lot of what I'm seeing of the patients that I work with. That they want to be adherent, but it's not in their lifestyle with all the chaos going on. And then there's unwittingly, and this also may be what's going on. It's misunderstanding, it's incorrect technique or no parenting skills. So yes, they've been taught how to take the medication, but they're unable to do that. They misunderstood. That is non-intentional. So they want to do right, but they don't have the skills. So primary adherence to medication means you've given the patient the prescription and they went and got it filled. Secondary adherence is what they did with that medication after they got it filled. So the first type of adherence is, did they even fill the prescription? And if you look at it in pediatrics, antimicrobials, 94% of patients are adherent in at least filling that prescription. Asthma meds is 88%. So 12% of our patients that we give a prescription to don't go and get a prescription, don't go get it filled. Neuropsych is 85 and dermatologic is 83. So again, primary adherence is the first step in medication adherence. Then secondary adherence is, what does the patient do once the medication is in the home, and do they take it as prescribed? Most studies on adherence, and the studies that I'm going to present to you, are looking at secondary adherence. It means they've got the medication, it's whether they take it. Adherence is not a fixed event, it's a changing process. So they may be adherent one part of the month, and then over the summer they decide they're not going to be adherent. Understanding that is both cultural and the social context, and it's how they integrate medication taking into their daily, everyday life. And if you're asking somebody to do something 3 times a day, 2 times a day, you really have to integrate that into your life. I'm going to just skip. So the Royal Pharmaceutical Society in 1997 decided, or said, that the most salient influence on medicine taking are the beliefs that people hold about their medication and about medicines in general. And I think that's really true. If they don't believe in taking the medicine, it's not going to get taken. So I'm just trying to tell you, list some of the factors that are associated with why our patients are not adherent all the time. So some of the predictors of poor adherence are the complexity of the treatment. Is it once a day, twice a day, 4 times a day? The cost of the medication, do they have a copayment or both? The duration of treatment. Somebody can probably take a medication twice a day for 10 days, but when you say you got to take this for 6 months, that's a long time to be adherent. Presence of psychological problems in the caregiver. We talked about this in the session I was in before. There's a lot of maternal depression, caregiver depression out there. If they're depressed, they may not be able to function and take the medication or have their child take the medication on a regular basis. Inadequate follow-up and inadequate discharge planning. Did we educate them correctly on how to take the medication? Parents' lack of belief in the benefit of the medication, and my soapbox is poor provider-patient communication. Did we accurately communicate how we want you to take that medicine? So this just shows you the rate of adherence by the frequency of taking the medication. And this was an old study in 1991 in pediatrics by Coots. So if you prescribed a medicine, BID, and he did electronic surveillance, 71% of the patients took the medication for BID. TID, it drops down to 34%. And when you ask somebody to take something 4 times a day, 18% of the patients were able to be adherent. So that just lets you know that QID is not the best way to go. Then Milgram, this is another classic study in 1996. He did electronic monitoring of inhaler use. So you can put these electronic devices on inhalers, and it counts the number of times you actuate it, the time of day you actuate it. And so what I want you to see, I don't know if there's a pointer, is for inhaled beta agonists, look at the median. That's the dark line in the middle of the box. So by diary report, that's by self-report, about 80% of the parents said, yeah, I took beta agonists. I took the beta agonist that day. The chronologue, or the electronic measurement of the medication, was down to about 62%. But then you take the dose at the correct time, it drops down. If you look at inhaled corticosteroids, it's even more striking. So in the diary, almost 95% of the parents said, yeah, my child took the inhaled steroid. The electronic monitor said 60%, but if you looked at, did they take it at the right time, like BID or QID, only about 1/3 of the doses were taken at the right time. So this was one of the classic studies that talks about adherence and shows us evidence that our patients do need help with adherence. Another study by McQuaid, who's a researcher in asthma, children take approximately 50% of prescribed doses of inhaled medications. And again, some other researchers have shown parental health beliefs may be more related to non-adherence than medication shortcomings. So what are some of these parental medication health beliefs? Fear of medication, dislike of controller medication when the child has no symptoms. So, we're asking them to take it throughout the summer. The child doesn't have any symptoms. They want to know why they have to do that. Too much medication they believe their child's on, and difficulty anticipating refills. Now, I think we all could help with that a little better. So the fear of medication is fear of side effects. A lot of parents seem to still think that growth is affected by regular use of inhaled steroids. That's really not, that's really a myth. It's a very small amount over your lifetime that your height would be affected. Fear of dependency, I've had patients say that to me. I don't want my child to become dependent on albuterol. I don't want my child to become addicted to inhaled steroids. Fear of too much medication. And so by not being non-adherent, you reduce some of these fears because you don't give your child the medicine. I'm not going to do that. So, poor doctor communication. This is another quote by DiMatteo in 1994. 50% of patients leave the general practitioner's office without knowing what they were told. And I believe that too. Because if you've ever been to the physician and you're getting all this stuff fed you, and you walk out and you're not sure what they said. So you should always take an advocate with you, I believe. Another interesting thing that I wanted to bring up was, what age are children independently taking their medication? And I was surprised, but the data is here. So Peyton Eggleston, an allergist at Johns Hopkins, did a study and asked parents, when do they allow the child to be independently responsible for administering their medication? And these were asthma medications. So the graph, when you look at the dark bar, that means it's unsupervised. So what I want you to see is by age 8, about 40% of children are self-administering their asthma medicines. By age 9, 50%. And by 11, almost all children in this study, and these are inner city children, were self-administering their medication. So that means we should be including the child in the discussion of medication with the provider. So another study by Marilyn Winkelstein, who's a nurse who did a study in home visits, she asked parents, again, when do you allow your child to self-administer their asthma medicines? But she took it a step further. She asked, what other activities does the child do that you can relate to that age that you would allow the child to do? And she asked, what are the reasons that you think about when you ask your child to self-administer? They said children know best when they need their medicine, was 80%. Parents at work, I think that's an important factor, 60%. Children can find the medicine and give it themselves, 60% of the parents. Children do other things independently, 60%. And it's time, I just know it's time for my child to learn to take asthma medicines. So what she did was ask, okay, out of these other activities, what does it correlate, like what is a similar activity that you relate to when your child could take asthma medicine? And as you see, they can cross the street by themselves. If they can cross the street by themselves, they probably can take their asthma medicine. They can do their homework, but they cannot go to McDonald's. If they go to McDonald's, that's an older task, is what she found. If they wanted to go to McDonald's, they had to be older, but they could take their asthma medicine. So I thought that was very clever that she looked at other activities in the home. So some strategies for improving adherence: communication, education. One is tailoring medication regimen to the family. We got to find out how can we make this easier for the family. And so what I think, and I think what Dr. Kay was emphasizing in some of her talks is emphasize the value of the medication regimen. Emphasize it with the parents. They need to know how important it is. Ask parents and the child their feelings about taking the medicine and about the regimen. Is it too hard? If it is, what can we do to help you make it a little easier? Simple, clear instructions. I can't stress that enough. It really has to be simple. Customize a regimen to the patient's wishes and obtain support from the family. So if the mother's depressed or not able to really oversee this, is there another family member that can oversee the child's medication? I just want to end on using pharmacy data. Pharmacy data is where you call the pharmacist or you call the insurance company and get the pharmacy records over the past 12 months. It's an objective measure of adherence. It's convenient, it's low cost, you don't have to pay most of the time, and you also can look at patterns. I showed this in my previous episode. It's a calendar giving feedback to the parent of when they filled the medications. We also feed this back to the child's physician. So the child, they got the 12 months, albuterol's in red because that's a very important medication. This child had 4 fills of albuterol in the past year. That's a little over. It's not as high as some of our other children.